Welcome to the Chest Guidelines podcast, where we apply our clinical guidelines to actual patient cases and see the practice doesn't always follow a straight line. I want to welcome our audience back to our podcast series on our chest evidence-based clinical practice guidelines. And today we're going to be focusing on one of our recent set of guidelines on the management of early stage non-small cell lung cancer. It's my pleasure to welcome my co-host, Dr. John Howington, and our guest today, Dr. Sudish Murthy. John, would you say hello and introduce yourself?
Yes. Hello. So I'm John Howington. I'm a general thoracic surgeon, and I currently have the privilege of serving as the 87th president of the American College of Chest Physicians.
Welcome, John. Thanks for being here today to help me navigate, since I am not a lung cancer specialist. Dr. Murthy, could you please say hello, introduce yourself to the audience?
Hi, I'm Sudish Murthy. I'm here in balmy Cleveland, and I'm truly honored to be asked to participate in this important podcast.
Well, we're really excited to have you here. I'm excited to have both of you, particularly having two surgeons to walk me through some of the decisions that are made in these cases that, of course, as a practicing pulmonary critical care physician, aren't part of my daily workflow. And I think that that may be true for a lot of our audience. And they're going to be very curious about the decisions that you both make on a daily basis. So as I understand, Dr. Murthy, you have a recent case that will help us explore some of the guideline statements that revolve around the management of stage 1 lung cancer. Is that correct?
Yes, Dr. Moores, I think I have something for us to hopefully help our listeners understand some of the nuance and some of the quandaries that we find ourselves in when we're dealing with early stage lung cancer. And my bias, of course, as you alluded to, is that unfortunately I am a surgeon. So I may be often wrong, but never in doubt, of course.
I've heard that line from my co-host, so.
A chance to cut is a chance to cure. That's our motto.
Okay. Well, I'm excited about that because as I read these guidelines, there definitely were areas that look new, and as you used the terms, they clearly looked nuanced, and I'm hoping we can dive into some of those as we think about this story of your recent patient. So why don't you give us a little background into your patient's, what was your patient dealing with, and what did you know at the time you first met the patient?
All right. So this is a very recent patient. So she's a 49-year-old woman who was a never smoker, and she had come to medical attention some 5-6 years before with a pituitary adenoma that was symptomatic. She had undergone a transsphenoidal resection of that adenoma. And on routine surveillance with MR scans of brain, there was a subtle recurrence of that adenoma that mandated that she would have a re-resection attempt. Well, as part of the workup, now 6 years later, she just underwent some surveillance scans just to make sure that there was nothing else going on. She's a very healthy woman, aside from the adenoma. Well, on one of those scans, which was a chest CT, a unsuspected occult lesion was noted in the left upper lobe, in the apical posterior segment. There is much more to that, given what we would consider a very low risk profile for lung cancer here. So the lesion itself was fairly ominous, actually, when we first looked at it. It was spiculated. It was sitting kind of close to the trifurcation of the upper division segments of the left upper lobe, segments 1, 2, and 3, somewhat posteriorly. And when our radiologists had seen it, they had measured it initially as 1.8 by 1.3 centimeters in dimensions. Of course, it's 3 dimensions. But there were a fair bit of speculations and sale signs that extended what someone could have reasonably thought as out to the visceral pleura, close to the chest wall, some of these tendrils extending from the center of the tube.
That does sound a bit suspicious from my days dealing with lung cancer.
Yeah, I think that any one of us who would have seen this, and of course her physicians at the time were equally intrigued by what this might be, and she was updated. And you can imagine this is a woman who's coming in for a reoperation on a benign parathyroid adenoma, and suddenly, surprise, you've got a lesion that looks somewhat ominous. So, after education and reviewing some of the algorithms involved, we decided to continue forward, or at least her medical care team did. And as is somewhat standard for these types of workups, the next thing that follows a incidentally identified nodule, particularly in a never smoker with very low risks, would be a follow-up CT scan. And it's dealer choice depending on the specific appearance of the nodule, where someone would somewhat intercede before that 3-month follow-up or 6-month follow-up scan with a PET scan. So this again gets to the eye of the beholder and the concern of the treating physician about what this might be. If there's a very low concern, then I think many of us would probably sit pat with a follow-up CT scan in the 3 to 6 month window. But if the lesion, independent of what you would expect as a pre-test probability for cancer, so in this woman, never smoker, no emphysema, totally normal lungs, no family history of cancer in this woman. So she again, very, very low pre-test probability of cancer. But the appearance of the lesion was somewhat ominous. And actually, it prompted her treating physician team to move ahead with a PET scan instead of waiting for the follow-up CT scan. Now, that PET scan was done about a month after the index CT scan was done. And the PET scan showed very, very low activity in the lesion. The SUV, the standard uptake value of the lesion itself, was less than the blood pool, with a max SUV of 1.8. And for many of us, we would consider that lesion to be negative on a PET scan.
That makes sense.
Yeah, I'll weigh in those, as Sid and I know, when a lesion is part solid and part ground glass, many of those suspicious that they'll be adenocarcinomas, many of them will be low grade. And so we're not surprised when they're not PET avid, if they had that kind of look of a lipidic adenocarcinoma. So that in itself, at least in my hands, doesn't completely rule it out. And we have the benefit, Sid and I, that, we've had over the course of 20 plus years, patients where we've looked at a CT, taken that patient based on the tumor board's recommendation to the operating room, wedge out a lesion, and then we get verification, cancer versus not cancer, and that's imprinted in our brain. And so it impacts our judgment when we look at something and say, I'm worried about that lesion. I'm not comfortable to continue to follow that. Did you have that sense, Sid, when you looked at this lesion?
Yeah, I was still not in the picture yet, but having gone back to the beginning, when I looked at that first CT scan, I was happy that they had actually gone to a PET scan early, because it did appear to be far more concerning than I would have expected in a never smoker for a benign lesion. This did not look really like that atypical adenomatous hyperplasia, that classic ground glass that we struggle with now. We see a lot of never smokers these days with who get a CT scan incidentally. So we see a lot of these ground glass. This was not a ground glass lesion. This did have a solid component and did have some significant spiculation.
I'm thinking, Sid, as a pulmonologist, if I'm the person, the either primary care or pulmonary doctor that is doing this evaluation, and I see the initial CT scan, and by your description, I would be concerned. And then I decide to get the PET scan. And as you said, many people would call that, quote, negative. If I called you at that point, would you have said, maybe we ought to think about an operative approach right now? Or would your response potentially have been, well, let's not wait another 3 or 6 months, given that information. Let's repeat a scan earlier. I'm curious, if I had reached out, what would your thoughts be at that point in time?
So I will tell you that for this lesion, when I saw the scan, I thought the PET scan was very reasonable. I think the lesion itself made me think that I was a little uncomfortable about waiting, and I would have gone to some sort of biopsy. The lesion was fairly peripheral. It was probably reachable both transcutaneously as well as endobronchially. And that would have been when I saw that lesion, again, I have 20/20 hindsight here, but if I would have seen that lesion in real time, or you would have called me with that, I would have said, hey, why don't you guys biopsy and perhaps even stage this? Because I was leaning, when I saw the scans in retrospect, that this was a cancer, even though I didn't really know that at that time at all.
Okay. So if we fast forward, I'm assuming they did not call you at that point, that they did some follow-up, and did they eventually try to do that biopsy before referring her to you? And, was there anything from the patient perspective that affected this that you know of, or did you just sort of meet her when all of this had happened?
I did do that, but I'm happy to report that the people on the front end were just as concerned as I would have been on the back end, having seen the material after the fact. And their algorithm, which again, there is a lot of nuance. This group went from CT scan to PET scan, even though the PET scan was negative. They went, at that point, a few weeks later, they went for bronchoscopy with the latest robotic platforms and staged the mediastinum. Now, that information takes us a little bit more wayward here because the bronchoscopy was negative. Now, the finding on the bronchoscopy, they found some benign epithelium, respiratory epithelium, and then they got some blood back. Now, having looked at the images in retrospect on the robotic platform, they were in the lesion, for sure, looking at it. There did look to be an airway that traveled there. While they were there, they also looked at local lymph nodes. They looked at those in the central mediastinum, in the ipsilateral hilum, so the left hilum, as well as in the contralateral hilum. And the only lymph node that they thought was met criteria for biopsy happened to be in the contralateral hilum, a level 11 node, which was biopsied and just showed normal lymphoid tissue. The rest of the lymph nodes, based on standard EBUS criteria, based on size, consistency, etc., were thought to be negative. So their bronchoscopy demonstrated no evidence for cancer.
So what did they do at that point?
So you have this fairly ominous lesion, low-risk person, negative PET scan, negative biopsy. So I think they did the most reasonable thing, which was to get a CT scan, which was read as stable by the radiology team, and it was all done at the same center. So it was comparative. It was the same group that was using their comparative read. It wasn't the same radiologist that read the next film, but that radiologist said in the dictation, lesion stable, 2.7 centimeters by 1.4.
Which sounds like it almost doubled.
And that's what you would think. The original lesion was measured at 1.8 by 1.3 or 1.4. That was the original. So this information gets back to the care team, and they look at stable. That was the first thing in the dictation. And the second thing was 2.7 as kind of an afterthought. Now, the pulmonologist who was managing this patient, I think, looked at that and they said, wait a second, this is over, almost a centimeter larger in one of your diameters. What is going on?
So I assume that based on that CT and the conflicting evidence of maybe it's stable, maybe it's bigger, that was when you were pulled into the decision making?
The beeper went off, the phone rang, and that we brought her in then. So
how did that conversation go with the patient? What were you thinking, and what were the options in terms of where you went from there?
So there's a few things about the actual nitty-gritty of the read that did suggest something slightly more ominous than a granuloma, okay, or an old scar, a burnt-out pneumonia, which are in the differential for someone like this.
Sure.
So kind of concerning CT scan, negative PET scan, negative bronchoscopy, stable nodule. And I went back and I looked at the overread, the second read 2.7 versus 1.8, and I looked at that and they were the same. The appearance looked fairly similar. And I think that the difference was someone was reading out to the end of the spiculations and someone else was focused on the real solid component. So you had these tendrils extending out. And I think that is something, I think, as clinicians and surgeons, we have to really understand what is being reported. And if you, on your own, whatever electronic medical record system you use, but if you bring up your films, you will have some, poor man's calipers, poor woman's calipers. We don't get the same definition as our radiology colleagues, but you can do reasonable measurements just to make sure that what is being reported is in fact what you are finding. So when I went back and I heard I saw 1.7 on one film or 1.8, and I saw 2.7 on another, and then I was playing around with my own calipers, I came to the conclusion that one radiologist was reading the more central solid component, whereas one radiologist was extending it out to the end of these spiculations.
I think you're giving me a little PTSD of my fellowship and having multiple films put up, and I had to say, has something changed? But I think it's important. But what at this point did you think was the best approach? And again, how did that conversation go with the patient?
So I will tell you that this woman who unfortunately had this problem that we were working on, he was, whatever you say, doc, I'll do whatever you think, which really puts the onus to not do anything to her that we wouldn't do to us, right? I mean, that's all of what we do. So if it was me, what would I want? And I thought about it. Negative biopsy here, negative PET scan there, no change in growth. But as John had said this, it's at some level, it sounds like a duck and, walks like a duck. And you've got a pretty good sense of what it is. At least we do, because this is in our wheelhouse. So my sense was that I didn't feel comfortable standing pat and keeping her in surveillance, even though there was no interval change in size of lesion in about 3 months.
That makes sense to me. And so what did you think was the best surgical approach? What were some of the other options? And what did she feel about that? I'm hearing you say whatever, doc, so maybe that's what she said. But where was that decision point on the operative approach now that you're saying we're not going to let this sit?
Yeah, so we've already gone through the biopsy, right? We tried that, and we got an answer that said no cancer. When I looked at the CT scan, the lesion was fairly peripheral, within probably a centimeter of the posterior distal pleural edge, up against the posterior chest wall. And I thought, that she needed an intervention that was going to be a diagnostic intervention that would be diagnostic therapeutic, a lesion where we operatively potentially biopsy it and then take it out at the same time. It's whatever it is, even if it was if it was a bad dense histoplasma infection, something was a segment of that area was destroyed lung. It certainly looked like that. But
So I'll interject. So you presented it at tumor board. And
Yes.
on the multidisciplinary tumor board, how did your group weigh in?
So the group said if it was them, they would want it out. So I was thinking that from the beginning. And so that's what we suggested to her.
But the guidelines, Dr. Murthy, that could be a thoracotomy, or that could be a minimally invasive or a robotic approach. And that's something that seems to have evolved in our understanding and in the evidence over the last few years. And how did that weigh into the expertise of the group saying which approach should we recommend?
Yeah, well, I think that over the last 15 to 20 years, it has become clear to us that when it comes to operations in the chest, less is usually more. And we had end of last century, we had some randomized study that suggested that a minimally invasive chest lung operation was no better than a thoracotomy. But I think in Dr. Howington's and my years, it has become obvious that less invasive operations that are done to the same standard as you would expect for an open operation are better. They're oncologically certainly no worse, and at a minimum equivalent, if not better. And I think for a patient, they're practically much better for a patient. So if you have an operation that's no worse oncologically, and perhaps even better, and benefits the patient, I think we're in on that 100%. And in our recent guidelines, that is one of the first things that we cite, that if we have an early cancer, that we are always thinking about a minimally invasive intervention for that human being. Now, I will say that the minimally invasive platforms, they do bring in other challenges. So there is some technology that an enterprise has to have, whether it's a video camera for VATS and those contracts, or a robot for that platform. There are some other challenges about a small nodule. And one of those challenges is that you only have little keyhole 8 to 10 millimeter incisions that you're doing your operation through. Well, how do you find or feel a nodule? Can't really do that. So that puts the burden of the understanding of anatomy of the lung on the surgical team. You really have to know where the nodule is. You really have to have a very good sense of the anatomy of a 3D anatomy. You're looking at the CT scan in 2D. Now, there are 3D imaging systems that we now use to help us understand where a nodule would be. But when you're doing a lung operation, the lung isn't in the same geometry as it was on the scan. Because when we do a lung operation, we're completely collapsing the lung. So the geometry of the lung is not the same geometry as it was when it was scanned either on a 2D or 3D, preoperative study. So you have to put that into in your thinking care.
Yeah. I would not want to be in your place. I think that's why I'm not a surgeon. I would assume that we could maybe think about two things in our guidelines when you say, less is more. So not only the surgical approach is that minimally invasive, but also the extent of resection. And I think the case that you're sharing with us today brings up that conversation as well, right? Because it's peripheral, and it's depending on which measurement you trust. And let's just say, you've got an original one at 1.8, and when you look at it with your Fisher-Price calipers, it hasn't changed. So it would seem that this is one that could potentially be handled with a sublobar resection. And that's another decision point that the team maybe thought about and in talking with the patient. Are those things that you would highlight as well for our audience?
Yeah, I think that is even more critical. The idea that we need to preserve lung, especially in a case like this where you're not 100% sure of it. You think but you don't really know until you know here. So that was also something, not just minimally invasive approach, but you want to consider lung sparing operations. Now, as you pointed out in our guidelines, there's been a lot of recent randomized data which suggests for early stage lung cancers, if you have the technical facility, if you have the equipment, and if you have the appropriate lesion that happens to fit the operation, well, a less than lobectomy operation is equivalent in terms of cancer-related and overall survival, and done in randomized studies. So that idea of trying to spare lung while not compromising cancer cure, but hopefully giving them some downstream benefit in terms of lung preservation, is front and center in a woman like this, who, with a lesion, is in an area of lung where I think what we call S1 plus 2 and 3. So we used to call this the apical trisegmentectomy, segments 1, 2, and 3 in the left upper lobe, sparing the lingula. We thought would be an excellent operation. But then again, you brought up you're conflating this other issue about the size of lesion. So our randomized data on this kind of approach is really pedicled on lesions 2 centimeters or less, peripheral in location, amenable to segmental resection. So those are the 3 criteria.
Are there things, John, as you're listening to your colleague, that you would highlight differently? Or, I mean, I think we're kind of getting at that, as Dr. Murthy has said, this one's tough. It's location, but it's size. What else would you highlight for our listeners?
It's under 2 centimeters. It's peripheral. And so that makes it an ideal lesion for sublobar, and ideally segment, but there are occasions where a therapeutic wedge resection is appropriate as well. But as he mentioned, this one bordered different segments, so segmentectomy is likely the best approach. It's level 1 evidence that minimally invasive surgery is less morbid, has a lower mortality, and better tolerated by patients. So it's minimally invasive approach. And then for a case where either it may be a benign lesion or it potentially is a low-grade tumor and the patient is going to live long enough to potentially have a second cancer, you want to spare as much lung tissue as you can. And so that would be in my mindset as I'm doing this.
Sure.
1, not to do a lobe for benign lesion. 2, if I can give her a good cancer operation, spare lung tissue so in a survivor she has options in the future.
Okay. Dr. Murthy, could you just summarize what procedure you did and what that pathology showed, and then maybe we can explore one additional question based on that.
All right. Well, we had a radiologist reading this as 2.7 centimeters. So we have that other, kind of funny narrative in this thing. But again, I think when I looked at the films, I'm looking at the solid component. And I think that's really what our guidelines are really centered around, as Dr. Howington was saying, and 2 centimeters seems to be our cutoff. And this did look like he could very nicely fit into a trisegmentectomy or a segment 1 plus 2 and 3 on the left side. So that was the operation we did.
Okay.
And we did it on the standard robotic platform. And we treated it as a cancer at the time of the operation. That was both the diagnostic and the therapeutic intervention. I didn't do a pre-wedge of it because I couldn't really even feel it. So the frozen pathology in an operating room came back as invasive adenocarcinoma.
Okay.
So we had done the operation thinking it was that. And hearing that, we did an extensive lymph node dissection, and I think we sampled excavated in her 4 different central mediastinal N2 stations and 3 different hilar N1 stations. So we had 7 lymph node stations draining this area that we have sampled. And those were all Rethers negative. So her final P diagnosis was PT1B N0. And from our rest of our scans, we threw in the M0 because she'd had brain imaging and she'd had, further pituitary adenoma, PET scan, etc. So her pathologic stage was a stage 1A.
As I read the guidelines, obviously she is going to be followed, but this would be the end of the story. The nuance that I see in your guidelines is this idea of, as you transition from 1A to 1B, if you see a mutation addicted tumor, that you may want to consider targeted therapy. And so in the stage 1B, looking for certain mutations and using targeted therapy, she, again, by this staging, would not be in that category. But what if she was someone that said, I'm concerned about that, I was really close in size, and should we look at my molecular and genetic markers and say, is there something else I should do? Do you have patients that do that? Is that something you all ever discuss at tumor board post-op when you have all this information?
Surprisingly for her, this histopathologic subtype she had fell under the moniker of the dominant type being micropapillary, which is a fairly high risk. That and the solid histopathologic subtypes are the two higher risk of several different types of adenocarcinoma of lung, and they often are the most poorly differentiated, which hers was. So it was a surprisingly ugly lesion given negative PET positivity and no interval growth over 3 months, because these are the ones you expect to be doubling in size every 3 to 6 months, so this kind of pathology. So the final size was read as 1.7. So that put her squarely into stage 1A. Well, I think a standard of care or an emerging standard of care at most centers would be that the pathology not only gives the descriptor of the histopath, the size, degree of differentiation, but all of these lesions now are getting assessed and assayed for various activating mutations, usually EGFR and ALK mutations, as well as the presence of PD-L1 in investing cells in these tumors. So for her EGFR was negative, which is, I was actually expecting it to potentially be positive. She is of Asian descent. I think she's from the Philippines. And there is a fairly high percent of those women who are never smokers who will present with EGFR activating receptor mutations. But she was EGFR negative. Her ALK was equivocable. So it wasn't negative, it wasn't positive, it was mildly staining. So we're calling it negative whenever we see that. And her PD-L1 was greater than 50%. So you have a stage 1A healthy woman, negative margins, and we really staged her lymph nodes quite well. I don't think we could have staged them any better than we did. So we're pretty comfortable with that moniker of stage 1A on her. So most of the data going forward, and having been backwards now going forward, even in the days of, even in these current days of immunotherapy and targeted therapy, would suggest that she would have no benefit from either approach if she were a candidate. So immunotherapy, you'd say, boy, it's PD-L1 greater than 50% might be reasonable. It turns out that the risks outweigh the benefits in someone like this. People don't realize there are risks to immunotherapy, just like there are risks to targeted therapy. And if her lesion would have gotten her to a stage 1B by size criteria, principally, and if it was an EGFR positive lesion, then that does bring into play some targeted therapies. There are recent trials, the Adura and the Alina trial, looking at various targeted agents for various activating mutations that predominantly begin at 1B to stage 3. We haven't tried those in stage 1A because there's some morbidity from these things. And I think her predicted survivorship and following it out to 5 years, we'd predict that her 5-year and cancer-free survival roughly are coincident, or overall and cancer-free are coincident at this age. It should be somewhere in the neighborhood of around 94% if she fits the standard curve that we generate here, based on this kind of operation with this kind of local lymph node assessment. So that, for her, the counseling would be right now your best off standing pat. That doesn't mean that you're not getting scanned every 6 months out to years, and then every year out to that for 5. And then in someone like this, it turns out the greatest risk of getting lung cancer actually isn't smoking, it's having had lung cancer. So that after she finishes this survivorship program, you might consider her in a surveillance screening program, maybe scan every 2 to 3 years, like you might for a heavy smoker.
Okay. Well, I think, I certainly want to thank you for sharing this case. I'm glad that she got the care that she did and that her prognosis is so good. I was wondering if, let me start with you, Dr. Murthy, and then I'll go to Dr. Howington. What do you really want our audience to take away from our discussion today? Maybe 2 or 3 really high level teaching points for them. What should they really remember from our conversation?
Well, this is a talk about guidelines. And I think guidelines are guardrails. And they're often, you got a 4-lane highway, you got guardrails on both sides. There is some room for individual interpretation and use of experience and other knowledge, which may not have reached clinical or critical significance to make it into a guideline. But that doesn't mean that it wasn't important knowledge. It just didn't pass the litmus test in respect to some statistical assessment to reach the importance that it would be on a guideline. But I think you have to use some of that. This kind of case does push a few different boundaries. There's probably more than one right answer on these things. I think a lobectomy would be a perfectly reasonable answer. And if you look at our guidelines, Dr. Howington would know this because he has written the last 2 guidelines as I have on this topic, that we suggest that a minimally invasive operation is critical. So that was one thing that we're kind of going to plant our flag in the ground on. But in terms of the specific lung operation, sometimes a segmentectomy is a more challenging operation, and your skill set happens to dovetail with a lobectomy. Those are what we think are equivalent operations. And someone with normal lung function, I don't think I could really be too put off by someone who said they got a left upper lobectomy with this type of lesion. So again, these guidelines are guardrails. There is room within the guidelines that allow for some laxity to, play into your expertise, your field of expertise.
Sure. Dr. Howington?
So I think the points I want to make is, and this is a good example of that, if you have lungs, you can get lung cancer. So even though someone has never smoked, is healthy, if you see a lesion on a CT and it looks suspicious, then approach it as if it was a lung cancer until proven otherwise. Because Sid and I both have in our career seen cases where lesions in hindsight we look at and go, oh, looks ugly, get followed for extended periods of time and progress, before the caregiver's eyes. So to avoid that. Also to remind folks that now in the United States, more women get lung cancer each year than men. And lung cancer is the cause of death in women more than breast, ovarian, and cervical cancers combined. So it's definitely a woman's disease. So don't take the fact that it's in a woman that you can disregard it because she doesn't smoke. You still need to work up these lesions. And then as Sid has mentioned, with a stage 1 lung cancer, as thoracic surgeons, we put our, flag in the ground. You cannot have a 3-star SCS thoracic surgery program if you're not doing minimally invasive surgery for stage 1 lung cancer.
Great. I think you both bring up wonderful points. As I mentioned early in our conversation, I'm not a lung cancer specialist, but I do spend a good degree of my professional life in the creation of guidelines. And I couldn't agree with you more, Dr. Murthy. I think I went into the field naively thinking this is going to be fun because the evidence is the evidence. It's going to tell us what we should do. And then you look at the evidence and you kind of go, huh. And then you look at risks and benefits, and you look at health equity, and you look at cost, and you look at feasibility, and you realize that the judgments that we all make have room. You realize that methodology can lead to a different evidence profile sometimes. And so professional societies who are really bringing together expertise can sometimes have different guidance statements on the same question, and understanding those nuances. But I think allowing our audience to really take the time to look at our guidelines, to look at the initial statement, and to use that as a starting point in the conversation with our patients, particularly nowadays when there is so much room for shared decision making. And here's where we're going to start, and here's some reasonable things we could consider. And let's talk about what we want to do and where we want to go from here. So I really want to thank you both for sharing your time and your expertise. This has been a wonderful conversation about a topic that, as Dr. Howington pointed out, unfortunately is a major health problem, and we're going to see a lot of it. I'm excited about all the progress we've made in treating lung cancer, and I know we're going to continue to do that, particularly with the two of you and the rest of your colleagues that spend your life really fighting this disease. So I want to thank you both again for your time tonight.
It's a pleasure and an honor. Absolutely. Thank you.
Yes, Lisa, thank you very much.